Good morning, everyone, and thank you for making time to join today's webinar. This session relates to work we've been doing over the recent years in developing a targeted interdisciplinary approach to meeting the specific needs of people living with chronic obstructive airways disease, referred to the community team at Hospice West Auckland. A bit of a mouthful, I know, but essentially we simply recognise we might not actually be meeting the needs of people with COPD under our service. We wanted to understand what our actual practice was, and in doing so, if there was any opportunities for improvement. So before I get started, I'd like to open with a karakia in my pepeha. E te whānau, e te hui, whaia te mataranga kia marama, kia whaia, takina mahi katoa, tū maia, tū kaha, araha atu, araha mai, tātou, kia tātou katoa. Tēnā koutou katoa, he uru I hou no tāwhiti, ko haina te whenua, tau aku tupuna ki ranga I o tautahi, ka mihi ahau ki taua whenua mi ona ori, ka mihi au ki te maunga kiki, ka mihi au ki te awa hopua, no oni hanga ahau, ko Oleg toko ingoa, no reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So thank you. My name is Oleg, and I'm a doctor here at Hospice West Auckland. And the outline for today's talk really is I'll first touch upon COPD as it is in Waitemata compared to Aotearoa, and why it might be important to actually have a targeted approach to COPD in hospice care. I'll go through the findings of the initial audit we did back in, I think it was June 2023. And following that, I'll describe what we've actually created in terms of an interdisciplinary approach, and allow members of our team to speak directly to their role. So I'm proud to work with, obviously, Katie Kim, our pharmacist, Marion Maritz, our respiratory physiotherapist, and Shannon Corbett, our community nurse. And each of them have a great deal of experience and skill in palliative care, and I'll look forward to hearing their experiences. I'll then give an update on where we've gotten to now with this new initiative. And it's about a year since we first launched. We launched in winter of last year, and we're almost getting into winter of this year. We'll finally close with a webinar and a panel discussion Q&A session, and that'll be led by Celia Palmer. So please do post any questions that you might have or might be generated through this webinar. So let's start with our first poll question. And I'd like to invite you to consider, over the past year, how many patients with COPD have you referred through to the hospice, through to our hospice, or any hospice potentially? And if you're not a referrer, then how many patients have you been involved in the care of that you're aware of have been referred through to a hospice with COPD? And I'll give you a minute to respond. And Fern, if you could show the results once the majority of people have responded to the poll. Can we see the results, Fern? Well, that's interesting, isn't it? 35% haven't, yet 42% have. That's a little bit bimodal there. But more than half either haven't or have only done 1, 2, or 3. Well, hopefully today's today's webinar will maybe go in some way towards turning the dial. It's just so that we have a frame of reference in Waitemata for COPD. Here's the population data that HQSC publishes on their dashboard, and that can be accessed through their portal, through a portal, Tableau Public. And as you can see, there are about 2,900 hospitalizations a year in total for Waitemata, and that tracks roughly below the national average. Breaking it down by ethnicity, you can see the rate of hospitalizations for Māori is roughly about twice that of Pākehā. And also that the hospitalization rates really increase the older you are. When you specifically look at those already on triple therapy, which I guess we can assume is a surrogate for severe disease, the hospitalization rates are still quite high, but the age differentiation is not as stark. So Waitemata, if we add up all the ages over 2023, there are a total of 295 hospitalizations. And so keep this number in mind when we go through the webinar. And although this is fairly high-level data, it does give a sense of the significant burden of COPD in our community still. So knowing this, what is the role of palliative care, hospice care when it comes to COPD? There's been a lot of literature that relates to this and tries to answer this very question. And in summary, I believe it's mainly to do with addressing unmet needs and removing barriers to care. At some level, it's about patient's illness understanding. It's about managing exacerbations and the profound symptom burden that people experience. It's about, making sure that the healthcare services are well knitted together in a way that makes sense for patients. And not forgetting that the immense psychosocial and emotional impact of illness on people's lives. So this might be how it looks schematically in terms of patient flow, and I really wanted to bring your attention to the first step, which is the identification of severe cases in communication that they may well have palliative care needs, and this is obviously done by generalist practitioners, be they GPs or hospitalists, but unless this first step is done, then the patient is unable to progress through the pathway, irrespective of what their palliative care needs might well be. Unfortunately, as a palliative care doctor, I never have direct access to these patients. And it seems obvious on the one hand, but we can only become involved in patients who are referred through to our service. As to why we have these historically low referral rates, I guess that question is outside of the scope of this morning. But I'm sure you can think of a number of potential factors yourself. So with this in mind, we saw an opportunity to at least do a little bit better with the referrals we were actually receiving. Our aim was to improve delivery of care for COPD. With these four principles in mind. Firstly, to have a holistic and multidisciplinary approach. Secondly, to make sure whatever we designed was sustainable and systems-based. Thirdly, obviously you had to reflect best practice standards. And finally, we had to ensure consistency and equity. The first step was a spot audit, which we undertook 2 years ago now. And at the time, we had 246 patients in our service, of which 17 had a primary diagnosis of end-stage COPD. And this gave a prevalence of about 6.9%, which is less than half of that compared to the general population in Aotearoa. We thought this was because we weren't counting patients who might have had COPD as a secondary or comorbid diagnosis in our case mix, in our service, and also because our patients comprised the very severe end of the spectrum, as opposed to the overall prevalence rates that exist in a general population. So the first interesting finding was length of time under service. And as you can see, most had been under our service for less than a year. There is a significant tail of patients who were in service for several years. One patient in service for 5 years. This slide is a year old, so if that person is is still alive, then that person would be in service now for about 6 years. And I presented this data to the Hospice New Zealand conference last year. And anecdotally, when I spoke to a lot of the other hospices, they confirmed fairly similar experiences. So in terms of the actual patient profile, I won't go into it in any particular detail, but these are the main findings. The majority were Pākehā. All were appropriately severe. Most, if not all, were also on long-term oxygen. Most had already been, most had been referred by hospitals following exacerbations. To my surprise, 9 had never actually been seen by a hospice doctor. 9 were on an oral opioid, and 6 on midazolam nasal spray. 11 had never been offered Breathe Easy classes, which is an in-house group activity that our respiratory physiotherapists run. So even with this simple audit, hopefully you can see this really confirmed in our minds there was plenty of room for us to actually do a little bit better. So we created a working group and nutted it out and thought about what we could do, where our levers were, what our capacity was, and eventually came up with this process map. Sorry, it's a bit blurred and it looks a bit complicated, but essentially it comprises 3 parts. The first is the triage and initial assessment, which we changed and tweaked a little bit. The second is the interdisciplinary clinic, which is the lion's share of where we put our efforts and changes. And the final is the community case management, which we also tweaked a little bit. And I'll go through each of these in turn with the help of my colleagues. So at the triage and initial assessment, we now ensure that the admission criteria are actually met and purposefully capture COPD, not only as a primary diagnosis, but also as a secondary diagnosis for ease of future auditing. We had wanted the initial assessment to be undertaken jointly with a community nurse and social worker, given the psychosocial, emotional, financial, and personal impacts and functional impacts that the illness have on people's and their family whānau. But unfortunately, because of resource restraints, we couldn't really accomplish this. Hopefully, it's something that we will be able to offer in the future as our organisation grows. Following the initial assessment, patients are presented in our weekly interdisciplinary team meeting. As part of the initial assessment, we also included an additional welcome letter in the patient IA pack, and that informs them that this COPD initiative is new, and it just lets them know that we're trialing this. Ask them to be kind to us, and if we don't get it right, we apologise. We're taking baby steps, and we're going through an ironing out process. And a lot of our patients have been very sympathetic to that. After the initial assessment, as I said, they get presented an IDT, and the patients are subsequently referred through to the COPD clinic, where a lot of the new processes and activities occur. The clinic comprises core membership of a doctor, a physio, and pharmacist, and others as needed. If the patient is unable to travel to clinic, then we do have the capacity to see them at home and do it as a home visit, and stagger these interactions so as to not overwhelm them or exhaust them. Just as an aside, we've found coordinating and keeping track on patient flow has been helped tremendously by Zoom chat. We seem to be using Zoom chat for everything, and we do have a specific COPD clinic Zoom group chat. There are many other channels that we do use for different purposes. I highly recommend Zoom. So moving on to the actual clinic itself, as a doctor in the clinic, my role is obviously to do a comprehensive assessment. We've also adopted the COPD assessment tool, both to monitor symptom burden, but also to access inhalers under special authority. Another important task for me is to really explore patients' understanding. Oh, thank you. Patients' illness understanding, hold a prognostic discussion, and inform them of episodic care. If patients do eventually stabilize in our service, then we do let them know we may well be discharging them. I use the Serious Illness Conversation Guide to hold these discussions and also go through the shared goals of care form with them as well. And I must mention, I also work in Middlemore Hospital where I led the implementation project for the electronic shared goals of care. And so I appreciate how important it is for patient care, especially during hospitalizations and in preparation for uncertain recovery and deterioration. It makes a huge difference. Um, so what I'll do is hand over through to Katie next, and she'll go through in terms of what her role is in clinic. Katie, over to you.
Thank you. Oleg, I feel like you may have a few more slides to go.
Oh, do I?
Yeah.
Oh, no, sorry. I saw the poll and I thought it was yours. Sorry, no, you're right. It is. It's my poll, not yours. I preempted it a little bit. So moving on to our next poll. Compared to the general population, what is the rate of depression in COPD? Is the rate of depression less in COPD compared to the general population? Is it about the same in both populations? Does COPD have double the rate of depression, or is it more than double? And Fern, once again, if you could show the result once the majority have responded, I'll give people a minute or so to think about this. Right. Yes. Good. So most people thought it was about double, which is fairly accurate. Significant proportion also thought it was more than double, so which is also true to a certain extent. So in truth, COPD in patients, depression in patients with COPD is it's hard to pin down the prevalence rate, but it's about 2 to 6 times more likely compared to the general population. And this obviously increases with the severity of disease, number of hospitalizations, rates of debility, isolation, and age as well. Importantly, however, a hard statistic, COPD patients are 1.9 times more likely to commit suicide than those without. And so, this really emphasizes the fact why we take this very seriously and now always screen for depression. We use the Palliative Grief and Depression Scale as we find the IPOS, which only has one screening question about mood, is often insufficient as a standalone measure. And if you're interested in this, then I do refer you through to the last webinar that Dr. Imran Gopal gave on the assessment and management of depression in palliative care, which you're free to access through our website. So now I guess we're moving on, and I'll hand you over to Katie, our pharmacist, who'll go through her role in the COPD clinic. Thank you, Katie.
Thanks, Oleg. Morena, everyone. My name's Katie, and I'm a clinical pharmacist in the team. I'll be sharing what my role entails. So, one of the focus during my interaction with the patient is inhaler technique. We know from the COPD guidelines and through experience that poor technique is very common, and this reduces the benefit of an effective treatment. We use demo inhalers and whistle kits that look like this to assess inspiratory flow, check hand strength, dexterity, and the patient's cognitive skills, and this is then fed back to our hospice team. If using a metered dose inhaler, we ensure correct coordination and we encourage spacer use. And we can provide inhaler aids if a patient has trouble pressing down a puffer when using the MDI. And this is available free of charge at community pharmacies. For dry powder inhalers like elliptors, turbohalers, we do educate on strong inhalation technique. The figure on the slide highlights the common device errors and when switching devices may be beneficial. And during my assessment, we evaluate whether the current inhaler that the patient is using is optimal. Patients' preferences and practical factors are always considered when we're recommending a switch. Um, Inhaler technique is checked routinely and regularly, and it's reinforced by Marianne, our physiotherapist, at her Hospice Breathe Easy class. So moving on to the next slide, we've got another poll question. So how much more energy do people with COPD typically use compared to those with healthy lungs? I'll give you a minute to submit your answers. 20% less or the same amount, 5 to 10% more, 15 to 25% more, or lastly, 25 to 50% more. Thanks, Fern. Oh, and yes, the answer is 25 to 50% more. So most of us were near that range. Yes, so patients with COPD require more energy to breathe. And as COPD progresses, patients are at risk of malnutrition. Globally, around 30% of patients with COPD are affected by malnutrition, while an additional 50% fall into the at-risk category. This screening tool, the Malnutrition Universal Screening Tool, helps us screen for malnutrition, and I assist in providing advice around nutrition and also inform Dr. Oleg whether the patient meets the special authority criteria for the funded nutritional support or if they have one already. This is available in the ready-to-drink bottles or in powder form, and I found that patients were happy to be informed that there's a recipe book online on how to use Ensure powder to make soups, use it for baking, and fortify their existing meals. So moving on to the next slide. Smoking cessation. I check smoking status and recommend cessation if appropriate. It is still crucial for our patients to quit smoking as this reduces the COPD exacerbations and improves quality of life. We follow this ABC pathway, so we ask about the smoking status. If they do smoke, we provide brief advice and connect to cessation support. This is available within our hospice team. Nicotine replacement therapy with a 24-hour patch and gum or lozenges is a great start with other treatment options to add on if appropriate. Next slide, please, Oleg. I check patients' vaccine status and encourage to keep up to date. When a patient is interested, I liaise with the GP or pharmacy while it's topical and I strike while the iron is hot. Alternatively, the patients and family can book online using that link that Oleg's mentioned, bookmyvaccine.health.nz. Respiratory vaccines listed here, influenza, pneumococcal, pertussis, the COVID vaccines, all play a crucial role in protecting patients with COPD who are more vulnerable to these respiratory infections. And then you'll see here the varicella zoster virus that vaccine that's recommended. So a study found that there's a 2.8-fold increased risk of developing shingles in patients with COPD, and that's because of the immune dysfunction and the immunosuppressive effects of inhaled and oral corticosteroids. So always good to keep up to date. And with medication reconciliation, I check patients' medication history and do a thorough reconciliation. We often support back pocket prescriptions for prednisone and antibiotics to manage early exacerbation signs at home, which can avoid unnecessary hospitalization. For dyspnea, we may start a short-acting opioid, and morphine liquid is our first-line choice for this due to the strongest evidence base among the opioids. Opioids can relieve dyspnea by reducing the respiratory rate. And if anxiety is a factor that contributes to dyspnea, we may trial a midazolam nasal spray, but this isn't usually our first-line choice, and we trial it with caution. And if the short-acting opioid has been helpful and the use has been frequent, we can look at establishing long-acting opioids that have a 12-hour action, which can be taken once or twice a day. I also review the patient's eligibility under the Pharmac Special Authority criteria for the single inhaler triple therapy for those that are using 2 or more maintenance inhalers. This can simplify the maintenance regime, and it eliminates the need to use separate inhalers and helps with adherence. There is the option of the dry powder elliptor Trelegy, or a metered dose inhaler, and it's called Breeze Try. Trelegy has the benefit of the once daily dosing, but we have come across patients who prefer the MDI and would rather trial the Breeze Try, which is usually 2 puffs twice a day. And so we honor the patient's preference here. Okay, this wraps up the core areas I cover in the team. I'll now hand you over to Marion, our respiratory physiotherapist. Thank you.
Good morning, everybody. My name is Marion, and I'm the respiratory physiotherapist at Hospice West Auckland. My role as physiotherapist is to help patients with end-stage COPD better manage their breathlessness, anxiety, and functional decline through non-pharmacological means. During my initial consultation at the IDT clinic, I introduced the option of joining our Breathe Easy group to the patients. And I then give them a basic introduction to the group so that they understand what it entails. So our Breathe Easy group is a short-term patient program running over 3 weeks, with each session lasting about 1 hour. Each week focuses on different aspects of managing breathlessness, offering practical strategies and resources to help patients as well as their families live more easily with their breathing problems. The Breathe Easy group is based on the breathing, thinking, functioning model, which was developed by the Cambridge Breathlessness Intervention Service. And this model highlights the 3 predominant emotional and behavioral reactions to breathlessness that leads to a vicious cycle that worsens their symptoms. So breathlessness impacts the way patients breathe or their breathing, their thoughts or thinking, and also how they go about their daily activities or functioning. As you can see on the TV screen in the picture on the right, there is a diagram saying breathing, thinking, functioning model. And this is the diagram that we reinforce with the patients, giving them information to understand how each of these different components can increase their breathlessness and anxiety as well as functional decline. On the left is a picture of one of our groups. The groups provides a safe and supportive space for individuals experiencing similar breathing difficulties specialties to come together, share their experiences, and offer mutual support. We also encourage patients to bring along a family member or a support person because they play an integral role in reinforcing the information and techniques at home. Oleg, if we can please have the next slide. So in week 1, we covered the first aspect of the breathing, thinking, functioning model, which is breathing. We focus our attention on the understanding breathlessness and how dysfunctional breathing patterns use extra energy, which increases their breathlessness. We then work through practical managing strategies, including breathing techniques, chest clearance techniques, positioning, and the handheld fan. On the picture, I added a couple of the breathing techniques that we discussed with the patients: the calming hand, pursed lip breathing, rectangular breathing, as well as the handheld fan. And the feedback that we get from our patients is they really find the handheld fan very beneficial and easy to use, and that is their #1 go-to. With the breathing techniques, they really like rectangular breathing. They feel it focuses their breathing and takes their attention away from feeling breathless. We give the patient an opportunity to try the different techniques, see which one they feel work for them, and then we add them to their specific breathlessness management plan. Oleg, next slide, please. Then week 2, thinking. We talk about the strong emotional response that breathlessness can trigger and why feeling anxious and frightened will directly increase their breathlessness. We then discuss and practice a few techniques to soothe their nervous system. These include relaxation, mindfulness, and aromatherapy. And then towards the end of session 2, I assist each patient to create a personal breathlessness management plan. We work through the different tools that we've tried, and they can let me know which ones they found beneficial, and then we put it into their specific plan. Next slide, Oleg. And then in our last session, we explore avoidance of activities and functional decline, and how incorporating gentle exercise into their daily living can improve their breathlessness in the long run. We also work through energy conservation strategies and sleep hygiene tips. I find with the patients that we see, the end COPD patients, they have a fear for exercise or activities because of the reaction that it triggers. And when I explain to them that we will be doing gentle exercise and functional exercise, and that they'll be able to cope with it, they're more keen to join our group and to join the exercise group. So during the Breathe Easy group, our aim is to give patient-specific education and information, focus our management using the breathing, thinking, functioning model, as well as patient priorities. We reinforce their existing successful self-management strategies and add strategies from the breathing, thinking, functioning toolbox. We also trial different techniques to ease their symptoms and modify or substitute them if needed. Then, on the completion of our Breathe Easy group, we help transition the patients to our weekly exercise group that helps patients stay active, build confidence, and move at their own pace. For the patients that's not able to join our Breathe Easy group, I follow up with a home visit where I briefly discuss the breathing, thinking, functioning model. We then identify what they specifically need, and I do a personalized breathlessness management plan for them at home, as well as a home exercise program that they feel comfortable to do. Thank you, Oleg.
Wonderful. Thank you, Marianne. So before we move on to Shannon, I did wanted to mention that we also do strive to complete a COPD action plan for our patients during the initial interactions. I guess over the past year, my experience has been how surprised I am at the number of patients who actually have never actually heard of a COPD action plan. Sometimes it's actually quite difficult to complete the COPD action plan from the outset, as we need to get to know the patient's habits and their thresholds before filling in the various components in a constructive way. And that actually segues very nicely into Shannon's work, and she'll be talking about her role as a community nurse, case managing patients under our service. So let me invite Shannon to talk about her role. Thank you, Shannon.
Hi. We visit our patients at home. So initially we do an assessment that can take a good long time, and we try and get a good picture of our patient's experience. And this is what we do for every patient who is referred to hospice, but and going through triage. But there is a few little differences with the COPD patients based on this piece of work. It's not a cookie cutter situation. Every patient has different background experiences. Some of them have been quite involved in going through respiratory services at the hospital, might have even done the physio. Other patients have not had that engagement, have not showed up to those appointments. Typically, they have experience of multiple hospital visits. Some of them have a goal of trying to avoid that. We work on care plans, which obviously dyspnea, low appetite, fatigue, looking at sleep, anything that is relevant to them. We look at their comorbidities, what other things affect their situation. Often we find them a little despondent about where they're at. And I think that's where putting them on this track of the Breathe Easy class can reframe their thinking about their disease. Some people manage to get out of the house, and some people haven't been out of the house for a long time, and that progresses as well. So reorientating their thinking about their situation is a key part of how we manage people. Can we go to the next slide? So what makes big differences? Oxygen and positive airway pressure devices sometimes. So hospice have 5 oxygen concentrators. Obviously, people are prescribed from the hospital 16 hours a day often, and they have those devices. Sometimes people don't qualify. Long-term oxygen therapy is really valuable and a bit of a game changer for people. What happens when they don't qualify? Hospice have a lower threshold for qualifications than other services, but we may still end up, if we decide to give somebody an oxygen concentrator, having that concentrator in their home for a very prolonged period of time. BiPAP's the same. Who decides, who looks after the BiPAP once it's in the patient's home? I had a patient who had 7 critical admissions. In the last admission, they gave him a BiPAP. It has been a game changer, but he hasn't been back to hospital, but nobody follows up with that BiPAP. Continuous monitoring. So sometimes our input stabilizes the patient, gets them on a right track. We might feel like that's no role for us and discharge them for a period of time. Other times it's a progression and that we keep an eye on. We review them in rapid round just to keep track of where we're at and make sure that our goals of care are being met, looking at what we could address in addition. Hospitalization is a tricky one. Some people, that was their main go-to troubleshooting situation. They would, anything that deteriorated, they would head back to hospital. So do they want to go back to hospital? Do they want the blood gases? What can we do at home to support them in not needing to go back to hospital? And what does end-of-life care look like for COPD patients? That is dependent on their comorbidities. They are at risk of acute events, PEs. They're sorry. There might be the slow fade away, but there also may be a risk of something happening suddenly. Finding out whether they are prepared to go back to hospital and under what circumstances is important. For some people that really would like to avoid that ever again. And that's important information to have for their families as well. So advanced care plans are important.
Thank you, Shannon. That really cements the important work that you do in the community in supporting patients who are, absolutely vulnerable and may not actually have access to other health providers. So thank you for that. In terms of next steps, what have we found over the past year with this program that we've initiated? So over the past year, we've had roughly about 400 referrals through to our organisation in total, and of which 25 of these have been patients primarily referred with end-stage severe COPD. We have been keeping a check on those who have COPD as a comorbid diagnosis, but may have been referred for another reason, such as lung cancer or whatnot. And there have been 40 patients with COPD with comorbid diagnosis. So that's 65 patients out of 400. A new data point we've also been tracking since initiating this project has actually been smoking status. And to my surprise, gosh, 29 patients in our case mix are current smokers, 5 of which have COPD. And so smoking cessation work definitely is still absolutely relevant, even in a hospice setting. Another thing to note is the ethnicity breakdown in Hospice West Auckland for the referrals. And as you can see, the majority are Pākehā, with only a handful being Māori. And this is the opposite profile of this illness in the general population. Of the 25 patients so far that have been referred through to us with COPD, 2 have declined admission to service. 1 moved out of area, and 10 have since died, which leaves 12 actively in service. So we are hoping to repeat the audit sometime towards the end of this year. And luckily, we've got Miriam, an advanced trainee, starting with us, and she'll be supporting and leading this work. We're also thinking about developing a COPD patient portal on our website because the amount of information we've collected and resources we feel would be really nice to have it as a one-stop shop for patients to access because pretty much everyone's got devices these days at home. We obviously need to continue promoting, socializing, and collaborating with regional stakeholders. And this morning's webinar hopefully goes some way towards meeting that goal. And finally, depending upon the success of this program, we're looking to expanding this approach to the other non-malignant illnesses such as congestive heart failure, end-stage renal failure, and dementia, to name a few. So this brings us to the panel discussion and Q&A session, and I'd like to invite Dr. Celia Palmer, as well as the other contributors, Katie, Marion, and Shannon, to turn on their videos and audio, and Celia can lead us through any questions that you may have had during this webinar. Thank you, Celia. Celia?
Yep, thanks very much,
Great.
everybody. That was really helpful and interesting, and it just makes me realize how much we do need that interdisciplinary team approach to improve our quality of care for COPD patients near the end of life. And I know you guys have put a lot of work and effort into this program, so thank you for that. And we have had a number of questions come through from the audience, which is great. The first question was from Annie Joseph, who wants to know which of our team visits people at home. Maybe I'll just quickly answer that one. So that's any of our team can visit people at home. So we would often give people a choice. So they could come to our clinics at Beach Road, or if they're not well enough or there's other problems, then we would go out and visit them. And that's true of the whole team here that you've heard from.
Might I just be able to add
yeah.
to that, Celia? We do encourage people to come to clinic. I think there's something symbolic in that, in terms of stepping over the threshold into hospice house, but it also introduces them to the environment, to the groups. It destigmatizes. It shows them in terms of the variety of other therapists and therapies that are on offer, and it gets them out of the house. And so, you know, at least my attitude is I really like people and want people to come to clinic if they can. And we do have volunteer drivers who can support that if need be.
Yeah, so thanks, Oleg. So I've got a few questions for the panel. There's one question came up around the use of oxycodone liquid. Could that be used for breathlessness, and does it have the same effect as morphine? And what would you prescribe if the eGFR is less than 15? Oleg, or maybe Oleg, do you want to?
Yeah, well, look, you know, a lot of the literature has been done with morphine, and I do know that there was an article, what would be like 2, 3, or maybe even 5 years ago now, with oxycodone, which was actually negative, and that really threw the cat amongst the pigeons, because it did it did pose the question: was the dyspnea relief obtained by morphine not a class effect and unique to morphine itself? I think, you know, I don't know if the oxycodone study compared directly with morphine. I think it was just simply oxycodone versus placebo. So that question was never settled. It hasn't changed my practice. I still believe the dyspnea relief is a class effect. And so I would use oxycodone in preference if the person had moderate renal impairment. What would your practices be, Celia?
I think similar, to be honest. I think although even when we haven't got evidence, we often trial if things work for a patient. And that's where we have to, because the evidence or the lack of evidence in our practice is quite, you know, is there all the time. So we have to work in that space where we trial if things work. But definitely we would switch to oxycodone if the eGFR was a problem. And picking up on medication then, Katie, could you comment a bit more on the midazolam nasal spray? You said that we wouldn't use it that often, and I just wondered if you've got any other comments to add there.
Yes. So how useful the midazolam nasal spray is a question mark. So it's not something we routinely recommend for managing breathlessness in end-stage COPD, because there's no strong evidence that it directly relieves breathlessness. And so the overall benefit is mixed. So as I mentioned in the presentation, if there's an anxiety component and say other strategies like opioids or non-pharmacological approaches or like the Breathe Easy class that Marianne does, hasn't worked, then it could be considered, but we do want to be cautious knowing that there are risks and side effects like sedation and dependence. Is there anything else you'd like to add, Oleg? Do you prescribe midazolam nasal spray?
Yeah, well, actually, full disclosure, I used to like midazolam nasal spray and prescribe it historically, but my practice has changed and it's evolved. And I had a bit of a slap down at the Hospice New Zealand conference last year, where it was reminded to me by my peers that in actual fact, there is very little, if any, evidence for the efficacy of midazolam nasal spray in the setting of dyspnea. And so that's really fundamentally changed my practice. I don't prescribe it in general now, maybe for fairly unique and specific indications, but generally in terms of managing dyspnea in this setting, I don't use it. I have come across patients who do become dependent on midazolam nasal spray, and it seems to be a bit of a positive vicious cycle, and they use more and more and more and go through bottles and bottles and bottles a week. And by the time that is discovered, I think that the horse has already bolted. What on earth do you do about that? Because they do become benzo dependent, and then it creates a problem. I think if a person is experiencing anxiety, there are much better alternative psychotropics other than benzos, and also non-pharmacological measures to try and meet their needs. Yeah, so my practice has fundamentally changed, but I do appreciate that a lot of our patients still on referral have already been prescribed, already established on midazolam nasal spray, and that's a little bit of extra work for us to try and tease out and support them through.
Thanks, Oleg. And I guess we would also sometimes think about other anti-anxiety medication, like perhaps an antidepressant, an SSRI, or preference for a long-acting benzodiazepine, maybe rather than midazolam, as things are becoming clearer that people are getting dependent on the spray. Thanks for that. We have got some more questions coming through, so I'm going to ask you, Marion. We'd love to hear about the difference between pulmonary rehabilitation and Breathe Easy. And I wondered, as part of your answer, you could also answer a question from Alicia about how you tell people to use the fan.
Yeah, sure.
In particular. Thanks.
So I would say that there's a lot of similarities between pulmonary rehabilitation and Breathe Easy group, but our Breathe Easy group is a much gentler approach, and it is more focused on end-stage COPD patients as well as the rest of our palliative care cohort. Like one of my patients explained it, the Breathe Easy group is less grueling. We do our group over 3 weeks, and then they're transitioned into a low-intensity exercise class, where with pulmonary rehab, it is an 8-week course where they have supervised exercise sessions, higher intensity, twice a week. And then the pulmonary rehabilitation also has an education and advice component to it, like ours does. But the Breathe Easy group is more focused on the information and lower intensity exercise. Then the handheld fan is such an awesome technique. I love using it, always get good feedback. And how you're supposed to use it in research, say, keep it about 30 centimeters away from your face. But the main thing is you need to feel the movement of air on your nose, your cheek, and your lips. That stimulates the facial nerve that runs through the brain and gives them that feeling of relief of breathlessness. So as long as you feel that movement on your face, you'll feel the benefit.
That's great, Marion. Thank you. It's such a simple thing that seems to make such a difference to our patients. That's great. I've got some more questions. So for you, Shannon, I wondered if you would comment on the use of guidelines in Do you use guidelines and do you find them helpful?
Do you mean the assessment tools and
Yes, that's right.
to a degree, but I think a lot of them are focused on patients with earlier stage COPD. So like the pulmonary rehab, they're in a different phase of their disease. So probably what's more useful for us is individualized care plans. We have to look at, what are the issues for the patient in particular. Some people cope with anxiety, depression better than others. Some people have better family support. What stage are they at and what's going to benefit them? Keeping things simple for people, like giving Katie organizing yellow cards and getting medication reconciliation. All of those sorts of things are possibly more valuable than the ticking the boxes, but we do use those just so we can, because sometimes you find out information that is a opposition to what your impression is, which is, just opens up a discussion for people, especially those questions around coping and depression and anxiety and how they think about their disease. Those are good conversations to have.
Great, thanks, Shannon. And we've got another question coming through around, do you look at admission to hospital rates after patients become involved with you? Hopefully this would lessen. And also, do we meet the preferred place of death for our patients? Oleg, do you want to comment on the admission to hospital?
Yeah, I can comment on the first part. That's
Yeah.
absolutely a key measure we'll be incorporating into our audit tool. And so I'm itching for our advanced trainee to start with us in launching into this work. But absolutely, yes, we'll be looking at that admission to hospital rate as well. And how it goes subsequently following hospitalization. So there is the potential we may be able to do some qualitative component to hospitalization in the care that we deliver. Yeah.
Thanks, Oleg. And I can answer the second part, because yes, we do look to, we haven't identified it by diagnosis, but for our patients in general, we look at if they die at home and whether they meet their preferred place of death. And I think generally we're reaching up to the late 70%, 80% of people meeting their preferred place of death. But it would be interesting to look at that for COPD specifically as well. So yeah, that's work in progress. Keep working on that. We've also got a question about referral. How do you get referred to the service? Oleg, do you want to answer?
Oh gosh, yeah. Well, there are many portals for referrals. So if you are a GP, absolutely, simply an email or the e-referral, or if you're any other health provider or practitioner in any other scope, we do receive referrals. We generally, as you can see, often receive referrals following hospitalization, but we also do receive referrals from family and patients directly, and they can access that referral portal through our website as well. So yeah, we try and reduce the barriers in the bar to referrals in accessing our service as much as possible. Anybody can refer.
Thank you, that's great. And I think I've probably got time for one last question. Just wanting to know, do you ever discharge patients? One of our, and
Yes.
thank you,
Yes.
Shannon. Yeah.
So if our interventions have been successful and the patient is comfortable and we are feeling like there's nothing that we need to offer at this point, yes, we will discharge. Obviously the door is always open to come back. That can be valuable because having somebody on the books long term it's sort of another level that maybe they don't need. They don't need that visit. They don't need that interaction. They have other things that they can access for that period of time. So yeah, it's important to look at why are they on the books and what are we doing with this person.
Great, thank you very much. And I think that's the crucial bit, isn't it? Recognizing when we can intervene, when we can discharge people, but also being open to readmit them when we need to. Hey, thank you very much, everybody, for your presentation and panel discussion. I've enjoyed it, so I hope our audience has.
Absolutely. Thank you, Celia. And I would just like to quickly acknowledge the COPD Working Group membership before we do finish, and close with a karakia. Tūriki whakataha, homie, hui, taiki. Thank you and go well.